Good evening all. I'm Dr. Chaitali Nikam, heading Infectious Diseases section at ThyroCare. Welcoming all the participants to the series of webinar conducting in collaboration with Haystack IIT Mumbai. So today's topic for our webinar is how whole genome sequencing is enabling personalized treatment in tuberculosis along with the case studies. Welcome Dr. Dharit Shah, who is international pulmonologist and chest physician at Pramukh and Radiance Multispeciality Hospital, Ahmedabad.
Thank you, Dr. Chaitanya. Good evening to all of you. Here I am, Dr. Dharit Shah. I have completed my MD as a respiratory medicine from LG Hospital, Ahmedabad. And since maybe 1.5 years, I am practicing in Ahmedabad in different hospitals. Nowadays, I am attached with Pramukh Hospital, Radiance Hospital, and Dhakkar Super Speciality Clinic. My main motto is to treat lung patients very specifically, and I have very much interested in interventional pulmonologist also. So I think we can start with today's presentation. So you all know that tuberculosis have iceberg phenomenon. In each and every disease, we can see that iceberg phenomenon. But for tuberculosis, it is specifically for multi-drug resistant TB that India accounts for highest TB incidence in the world, affecting 2.64 million Indians in 2019 and killing nearly 4.5 lakh people annually. We can see that day by day, year by year, the MDR-TB prevalence is increasing, and the incidence is also increasing. By 2040, the proportion may be 12.4% to 12.4% for MDR-TB, and for XDR-TB it is 8.9%. So, what the fault part from our side, from doctor side? TB treatment is specific for specific patient. So there are suboptimal treatment, poor prescription practice, patient non-adherence to the treatment, and some of the doctor combine different drugs to the TB drugs. So it may convert to drug-resistant TB after time. So we can prevent that with this specific treatment regimen to the specific patient. So NTB, you all know that the National TB Elimination Program, the India have converted from RNTCP to NTEP, but NTEP also miss 10% of drug sensitive TB and 50% of resistant cases. There are lots of drugs other than the sensitive tuberculosis. For drug resistant TB, there are 15 to 20 different drugs which we are using to treat the tuberculosis. So we primarily want that it is sensitive drug or not. So for that we are using similar, even LPA with culture DSP, and now we are going to represent the whole genome sequencing to get each and every drug sensitivity report. So this is the current treatment regimen. You all know that if patient's sputum is positive, and from CBNAT, if your MTB detect and rifampicin sensitive, we are giving the drug sensitive treatment to the patient. But for resistant tuberculosis, we have different three regimens. First one is H-mono or poly-DR-TB regimen. Previously, we are also using shorter regimen, but nowadays we are shifting shorter regimen patient to shorter all oral bedaquiline regimen, and there is a longer regimen which called all oral longer bedaquiline regimen. So mainly there are three different regimens for drug resistant tuberculosis. So firstly, we can discuss about the ISONIAZID H-mono regimen. So if your patient is getting rifampicin resistance, isoniazid resistant on LPA, we can start the H-mono regimen with the help of rifampicin, ethambutol, pyrizinamide plus levofloxacin, which is fluoroquinolone. So the regimen is like, you can see the pointer, that 6 to 9 months of levofloxacin and with the help of REZ. So this is the H regimen. So we have to investigate 4 major drugs, whether they are sensitive or not. Then second regimen is shorter oral bedaquiline-containing regimen. So this is the new, which is just implemented in the NTEP within last 4 to 5 months only. And it belongs from 9 months to 11 months. 4 to 6 months, we have to use bedaquiline with levofloxacin, clofazimine, pyrizinamide, ethambutol, isoniazid high dose, and ethionamide. And after completion of 4 to 6 months, we can shift patient to a CP phase with the help of levofloxacin, clofazimine, pyrizinamide, and ethambutol. So we have to get the sensitivity report of each and every drug to start shorter oral bedaquiline regimen. Same thing with the all oral longer. In all oral longer, we are using bedaquiline, levofloxacin, linezolid, clofazimine, and cyclosporine for 18 to 20 months. So for that also we have to get the sensitivity report. So my main point is there are lots of many drugs which we are using to treat a drug-resistant tuberculosis patient. So before starting treatment, if we can get the report of sensitivity report, it is very much useful for patient and doctor also, that we can give the precise treatment to the specific patient. And nowadays there is another regimen which was investigated by NICS TB trial. It is BPAL regimen. It is just of 6 to 9 months with the help of pretomanid, bedaquiline, and linezolid. So we have to investigate these 3 molecules also, whether it is sensitive or not. So you can see in this slide that it will take minimum 60 days to get each and every drug, whether it is sensitive or not. So it is very much time-consuming investigation. So the mean duration of treatment initiation in the TB care takes an average of 65 days for a new patient or a retreatment cases. So to shorten this time duration, the whole genome sequencing will help each and every doctor that he or she get the report of sensitivity within a few days. So let me introduce what is whole genome sequencing. So this is the whole genome sequencing primary information. That whole genome sequencing is the analysis of the entire genomic DNA sequence of a cell in a single time. So in the diagram, you can see that from the sample collection, if sample has 100 nanogram of DNA, it will directly goes to the DNA extraction. But if there is no specific DNA or lesser number of DNA in the sputum, we can enrich the culture. So it will take time. But if your specimen has 100 nanogram of DNA, that second thing is DNA extraction. Third point is pre-sequencing preparation. Fourth point is sequencing. Fifth, which is done by computer, it is data analysis, and you will get the report. So it is a very easy and like in a proper manner investigation. So we can do that also. So what are the advantages of WGS with TB? So WGS is also WHO approved method to investigation of the TB, Mycobacterium tuberculosis complex. It is basically of barcode DNA multiple bacteria combination. Then we can investigate other than TB bacteria also. So if your patient is having comorbidity with TB, you can get the report of different bacteria also. That your patient is having TB with maybe staphylococcus infection or MRSA infection or anything else. So this is the advantage of WGS. Third point is they can detect a single nucleotide variant, whether it is insertion, deletion, copy number of structure, or large structural variation. So you can get the report of very different type of genes. And the main important part is WGS need just 100 nanogram of DNA particle in the sample. So if your sample is possibacillary in nature, we can also get the report from that specimen. I think for gene expert, it is 13 to 100 bacilli in this sample is required. So same, like your next question is, how many days is required by WGS? So this is the flow chart that WGS just required 12 days. If your specimen is having 100 nanogram of DNA, they will give you report within 12 days only. So if you have collected a sample of sputum and send it for seminar, it will take either 2 hours, or some laboratories are taking 2 days time in the government setup to send a report of seminar. And if you are sending a report of directly whole genome sequencing, you can get each and every drug susceptibility within 12 days only. So complete DST report, mixed infectious and heteroresistance, individualized treatment, and rapid result, which is the main advantage of EGS, which is WGS. So next part is, which are drug which is investigated by WGS. So you all know that Cebinat is having just a rifampicin sensitivity. First line LPA, rifampicin and isoniazid. Second line LPA, fluoroquinolone and SLID. Second line injectable. And if you are doing culture with DST, then you can get each and every drug susceptibility. But to overcome that investigation part, WGS has each and every available drug which are using to treat tuberculosis. You can get the report. It will take 18 different antibiotics. Test time is only 12 days. It is 99.8% specific and 85 to 98% sensitive, which is a huge number. It can also identify mixed infection and co-infection also. So these are the genomic type that you all know that ISONIAZID have INHA and CAT-G resistance. So you can get that genes also, that whether it is INHA resistance or CAT-G resistance, or for the moxifloxacin it is GYRA or GYRB. So this is also an advantage part of WGS, that for each and every drug you can get the report of genes also.